All makes sense, John. Okay, so let's go on here. Jennifer, what do you think of this case? We're talking about medial collateral ligament, ulnar collateral ligament.
So here it does look like there's thickening and increased signal within that anterior bundle of the ulnar collateral ligament. This could be a chronic strain type of picture, chronic tear.
These people, when they strain it, they tend to have some symptoms. Again, this is basically should be treated like a full thickness tear. And again, normal people don't need surgery if they have an ulnar collateral ligament tear. If they're an athlete and they want to get back to a higher level of play, then you may want to consider it. Michael, what do you think of this case?
Okay. So, along that, like kind of where the sublime tubercle is, we have this like extending ossification. So it's like pretty significant ossification of that ligament, or like even just maybe, yeah.
Ossification. Again, chronic disease. This is another chronic athlete who got hypertrophic disease, and this is just kind of the most extreme example that I've seen. Jennifer, what do you think of this?
Okay, so here again, we're looking at that ulnar collateral ligament, and there's some slight irregularity of the sublime tubercle, and some increased signal proximally. And there we can see an ossific fragment along the medial epicondyle. I'm not sure it's corticated, so it could be a remote injury of the common flexor. Procedure.
So this is actually the tunnel for the to fix the graft into the medial epicondyle, and this is the tunnel in the sublime tubercle for the graft, and this is the graft intact through here. So this is a procedure, and I think we've gone through the story of the Tommy John. I don't think we need to do that again. It was developed here in Southern California, and we worked closely with Curl and Jobe, and it was Jobe who was involved with developing this particular surgery. But basically, it's just a graft replacement of the ulnar collateral ligament, and the first person to ever receive one, the picture for the couch was named Tommy John. Well, one of the few surgical procedures in orthopedics that's named after the patient and not the surgeon. John, do you want to comment?
There are about 5 modifications in Campbell's of the procedure. It's the way it's done by Tommy John Jobe procedure. It's probably not done anymore. And they try not to. They may make a drill hole through the epicondyle for the palmaris graft, or one of the hamstring tendons as a graft if you don't have a palmaris in 25% of cases. But the distal one in the sublime tubercle, they just drill a hole into it. They don't go through it. And they don't use any interference screws, just sutures through and through. And the major part of this surgery is actually the ulnar nerve. That can be a problem because of wear and tear, degenerative changes that you see around the nerve. If you see any compromise, you transpose it anteriorly, and that's another ball of wax to deal with how you do it. So now when you get so many different procedures, you start thinking, which one would I like to do? And right now, as far as I'm concerned, I'm not sure I would want to answer that one because I'm not done enough to worry about. Hand surgeons are the folks that really get involved in this more than a general orthopedic surgeon.
Yeah, so, and then we'll be giving lectures on this in our Curl and Jobe conferences. Since John brought it up, I'd like to just give a little bit of the history of how the ulnar nerve plays in here. In the first Tommy John procedure on Tommy John, the fellow involved in the procedure, if we were going to conferences, you would meet him. His name's Steve Lombardo, who's one of the senior orthopedic surgeons at Curl and Jobe right now. And most likely what happened is that he over-retracted the ulnar nerve at the time of surgery, and they got an ulnar nerve apraxia. So he ended up with a palsy of the ulnar nerve when he got out of surgery. They ended up going back in and transposing the nerve, moving it from behind the condyle to anterior to the condyle. And over about 6 to 8 months, that resolved, and he went back into baseball and was probably a more successful pitcher after the surgery than before the surgery, which made this a very famous surgery at that time. And then for years, everybody transposed the nerve until, maybe a decade ago, or not everybody, but many people did. Now I think most people just handle the nerve very carefully, and they don't transpose the nerves unless there's some symptom before they do surgery. Because there are some complications having to do with when you transpose the nerve, because you have to take down a lot of the bone attachment of the muscles and tendons, move it anteriorly, and reconnect everything, and that has a lot of morbidity in its own right.
Yeah, there are multiple procedures to work with the nerve, and that's because not every, well, all that means multiple operations for one problem means that none of them are that great. And the surgery that was done for the first time on Tommy John, there was Jobe, there was Jim Tamboni, who's been team doctor for USC for many years, one of my ex-residents, and also Stark, the hand surgeon who did the palmaris longus. And I don't know how much he was involved in the elbow. I suspect a lot, because the general surgeons in orthopedics don't work on elbow that much.
Yeah, not at that time, right. All right. Here's just another example here. We can see a metal artifact here. We can see a tunnel and the medial epicondyle. This was another intact Tommy John procedure. Sometimes you can get metal artifact and not see the full graft because of the artifact, but you have to read around that. Okay, here's another patient with a graft. Let's see, whose turn is it? Is it yours? Michael's. Michael, what do you think of this one?
Okay, so post Tommy John, now 2 weeks elbow pain. I mean, I'm seeing basically a complete like fluid signal transversing where the ulnar collateral ligament should be. So if he did have post Tommy John, it looks like it's probably torn.
Yeah, so this is a graft tear. And you notice not only is there a tear here, but it's markedly thickened.
Yeah.
So there's a lot of wear and tear and degenerative disease in that graft, which probably predisposed to the graft tear. These can be redone. There are a large number of Major League Baseball players who have had multiple Tommy John procedures, but it becomes obviously much more complex and difficult when you have to go in a second or third time. Okay, Jennifer, what do you think of this one?
So this is a Major League Baseball pitcher. Here we can see these are two coronal images, arthrogram images of the elbow. And there is contrast signal intensity extending around the sublime tubercle, so it looks like there's a tear of the ulnar collateral ligament.
And then here we can see a lot of irregularity here, thickening, some metal artifact along what looks like a graft here. That's probably a tunnel in the sublime tubercle there. Here we see a lot of increased signal intensity and thickening of the soft tissues adjacent to the medial epicondyle. Now, and this
here, I think, if I may butt in, John, here's a situation where why I mention hand surgeons. This is a delicate procedure overall. This is not, they use dental drills now instead of regular drills, and things of that sort, to be very gentle. And orthopedic surgeons as a whole, before they do their residency, I mean, they're in their fellowship, sorry about that. They're just not trained well enough to do these. We don't do these that often. Most places don't see baseball players that often that need this procedure.
Yeah.
These kids wash out sooner than later.
Yeah.
And very few get into a situation where they need this procedure.
So this,
overall.
Right. So this is a person, it's another graft failure, but there are other things you need to look at when you suspect ulnar collateral ligament insufficiency. One is to look at the median nerve. So you have to look at that every time you do an elbow anyway, but certainly if you suspect ulnar collateral ligament injury, you've got to look at it and comment on it in the report. But the other thing that often occurs here, you also need to look at the posterior medial aspect of the elbow and the olecranon and the articular cartilage back here, which we can see edema within the olecranon in this location. And if we go to the axial images, what you'll often see is posterior medial compartment, you'll get a lot of degenerative change in wearing and chondromalacia back here. And this is part of posterior impingement. So this is that same Major League Baseball player. Notice on the CT, we can see all these subchondral osteophytes posteriorly here. There's the tunnel for the Tommy John procedure. Here's tunnels both proximally and distally for the Tommy John procedure. And this was kind of an end-stage pitcher's elbow. But we're going to talk about what happens, and I've got slides later, but let me just, I guess, being repetitive isn't terrible. What could happen if you have insufficiency medially, then you get valgus deviation at the level of the elbow. And if you remember, the olecranon is a long bar here that's attached posteriorly to the ulna, and it goes into a long trough, which is the posterior aspect of the distal humerus. And if you have perfect alignment, then the olecranon process fits nicely into the trough in the back of the humerus. But if you've got valgus deviation there, that long olecranon no longer fits nicely in the trough. It's at an oblique angle, and you get rubbing and erosion along the posterior medial aspect, which is right back in here. When that happens, you get loss of the articular cartilage, and you get bone marrow edema on the posterior medial aspect of the olecranon, and that's called, and you get these degenerative changes over time, and this is posterior impingement, which is a common problem in long-standing overhead throwers. And I think we'll come back to that, and I'll show some diagrams which make that clearer.
Well, there's a lot of twisting around the elbow, which shouldn't be there in humans when they throw that much. Individuals, people, humans were not born to pitch, not like that. We use spears and bows and arrows and things like that, but all of a sudden we got to baseball, and pitching is just not part of our anatomy.
Yeah.
And most pitchers are unusual individuals in terms of anatomy. Otherwise, they wouldn't be pitching.
Right. Jim.
Yes, I was wondering on that MRI with the ulnar graft, the thickening and increased signal there. at the medial epicondyle if that was just graft degeneration or some partial tearing.
And generally, it's when you get this much degenerative disease and interstitial tearing, it doesn't have the rigidity and strength that it normally would have, and therefore, when you put valgus load on the elbow, it gives, and that produces a kind of instability which leads to posterior impingement.
And there may be a little excess valgus in this elbow, John. What do you think?
Oh,
There's kind of a suspicion of a little more extra valgus.
maybe, but I can't really tell just on these images.
Well, I can't either, but I mean, it just seems like there is.
Yeah.
And this is chronic. This has been there for quite a while.
So, but
don't you think?
Yes.
Except for this area right here.
It's been there for a long while, and this is really due to chronic repetitive trauma because of the valgus deformity of the elbow in the throwing area when you have the throwing mechanism, which produces this bone injury and this articular cartilage injury, and this is what's referred to as posterior impingement. But I think we'll come back to that. I've got more discussion of that later. So that's true. So see, Michael, what do you think of this case? Another medial elbow pain in a picture.
Okay, so on that first image, it looks like we're seeing some, or both images, we're seeing edema within the muscle. I guess kind of like in one of the common like flexor muscles. I'm not sure which one.
This would be the pronator.
Okay. So I don't see like, I mean, it's edema, but I don't see like discrete fluid, so I just call it like a low-grade strain.
Yeah, this is basically a muscle strain. And again, this is part of the flexor side, and when you whip the wrist forward to release the ball, you can get strains of the muscles, which are important for doing that. Good.
All right, we have a 29.
I would, excuse me a second. I would think that most injuries that we see in baseball and other sports that there's throwing is muscular pain. It doesn't get to the traumatic injuries, i.e. Strains where surgical intervention needs to be done, etc. But fairly uncommonly, if I may use that term, what we see mostly is muscular injuries. That's because most people don't throw the ball that hard, where actually tears occur. The strains are common, though.
Thank you.
Thank you. All right, so here we have two images of the elbow, and it looks like we're still looking at the pronator teres, and there's some edema and fluid distally. So it looks like there's a partial thickness tear of the muscle.
So a grade 2 tear, because you've got kind of a focal hematoma within the muscle. Grade 1 would be streaky signal without focal fluid collection. Grade 2 is with a focal fluid collection. Grade 3 is a complete tear. So, and most of the data show that if you have grade 2, it takes a couple more weeks before you can get back into athletic activities than if it's just.
And this is kind of like an example of the muscle takes the strain first, and then from there on you get the ligaments and so on. Eventually bone and fractures and things like that. So the muscle is, I'm probably telling you things that you already know and have known for many years.
Okay.
Repetition doesn't hurt.
Michael, what do you think of this case?
Okay, so there's says rule out ulnar collateral ligament tear. I think the UCL is intact. There's quite a bit of edema within that adjacent one of the flexor muscles.
But the ulnar collateral ligament's not normal. It's thickened
Yeah.
medially. You've lost the fat pad here. And though on one cut you couldn't call it, but the next cut also showed that you got thinning and increased signal intensity proximally here. So this is really kind of a severe chronic tendinosis of the ulnar collateral ligament at this point. But then, as you said, that the patient has a tear here. This is actually a little too posterior to be the pronator. So what muscle might this be?
I'm not sure. Flexor digitorum.
Flexor digitorum superficialis. So those are the two muscles that are fairly commonly injured in overhead throwers. Notice that there's a little bit of traction edema here also to the medial epicondyle. So you've got three signs to show that you've got a lot of injury of this ulnar collateral ligament, and if they continue doing what they're doing, it's going to tear. Okay. Here's a patient with
A muscle fails first.
And so here's a football player who has medial elbow pain. We can see a lot of soft tissue thickening here and some increased signal intensity. But if we go to the stir images, we can see also a lot of muscle tearing and hemorrhage into the subcutaneous tissue. And here, this is again a superficialis tear here on the medial side. Different examples of injuries to the same mechanism.
Okay, so here there's some mild increased signal within the ulnar collateral ligament at the attachment to the medial epicondyle, but I don't see a tear. And there's some mild increased signal within that distal muscle. I'm not. Yes. Okay, so at the this is another muscle strain. I'm not sure if this is the flexor carpi ulnaris or which muscle.
We don't see the distal ulnar collateral ligament go all the way to the bone. So this is a tear of the distal attachment. We see a little eburnation at the sublime tubercle. So this is a patient who looks like has chronic overuse and now has a tear distally here. And there's probably some extravasation of fluid from the joint space through the tear into the muscles here. And then, but the patient could also have a muscle tear in addition to extravasation of fluid. And this was an ulnar collateral ligament and a flexor digitorum profundus tear. Okay, Michael.
Okay, so elbow dislocation. So there's a few findings. One, the ulnar collateral ligament looks completely torn. Then on the other side, there's probably at least high-grade sprain of the RCL, and then there's a lot of edema within the common extensor tendon, and there's bone marrow edema involving the epicondyle and probably that radial head as well.
Okay. Here are the sagittal images.
Mm-hmm. So we're seeing more bone marrow edema in the distal radial head and that condyle and kind of surrounding soft tissue edema, and that's probably maybe is that part of the annular ligament?
Probably the annular ligament and the capsule here has been.
Yeah.
The dislocation here and impaction against the posterior capitellum. And we can see a lot of the edema in the muscle strains associated with this dislocation as well. And well, what's that back at that location? What attaches there?
Back here?
Yeah. So this is, yeah. What
so would this be kind of where the lateral ulnar collateral ligament will come down?
Yeah, this is the lateral ulnar collateral ligament. That's also a little bit. This is actually closer to where the annular ligament attaches. And the lateral ulnar collateral ligament is just inferior to this. Both were torn in this patient.
Got it. Okay.
And we can see a lot of other tissue disruptions. Okay. So here's a 24-year-old female dislocation. This is only an hour after the dislocation. What do you think of this one, Jennifer?
So here we can see some neuroedema in the capitellum, and it looks like there's some irregularity of that proximal radial collateral ligament. It's probably torn, and also that common extensor tendon origin. It looks like there's fluid signal intensity on the far right image, so that may also be torn. And there's also increased signal intensity within the proximal ulnar collateral ligament, probably at least partial thickness tear and muscle edema and some hemorrhage. Yeah, more fluid throughout the muscles and edema.
Okay. Here's someone who's had medial elbow pain for 1 month after an injury. In this particular case,
What would you do with that elbow, Jennifer?
I would immobilize her elbow. I think this may heal on its own.
Yeah, if it's stable, you start mobility very early, within a couple of days. If it's unstable, you may immobilize it for a week or so and then start activity. You don't want to immobilize an elbow more than 3 to 6 weeks maximum. If you do, you're going to have a very stiff elbow that you'll never get back to close to normal in terms of mobility. Elbow is a very, very difficult joint to deal with immobilization. You don't want to immobilize the elbow only under certain circumstances. And dislocation is one of them. A recurrence of dislocations, like I said early on, 2%. So you don't worry about that. You worry more about stiffness.
thanks, John. So here's a 33-year-old male with medial pain 1 month after an injury, and we can see that there's a little bit of signal here, but on the PD fat set, we can see increased signal intensity within the common flexor tendon origin from the medial epicondyle, right in that location. And here we could see that area here. Here's the medial muscle, the flexor muscle mass coming in here. So this was an acute strain of the common flexor tendon. And it's not torn and displaced at the current time, but strained. Okay, Michael, what do you think of this one?
Okay. So on that far right on the axial, I assume that's a soft tissue marker, and it looks like there's thickening and increased signal at that common flexor tendon origin. And on the coronal, you can see that there's probably some fluid, at least some partial tear as well.
Okay. Yeah, so this was another acute tear of the common flexor tendon. Good.
What would you do with that?
What would I do with this?
Mm-hmm.
So it's not completely torn, so you could probably do conservative therapy if they're able to handle that, like using their flexors.
Yeah, you probably should
Put them in a
immobilize
splint,
that for a while.
like a wrist splint or something.
Yeah, immobilize it for a while. And or if you get really antsy, you might want to put a staple into it, or some sutures, tendon to bone. I don't think I'd get very aggressive with it, mainly because you have to immobilize.
Okay, so here we can see increased signal intensity within the common flexor tendon origin compatible with partial thickness high-grade tearing. And there's a lot of adjacent fluid signal intensity and edema. It looks like that proximal ulnar collateral ligament may also be at least sprained. There's some increased signal there as well.
Okay, Michael, hang gliding injury.
All right. So this looks like probably like an avulsion type fracture. Almost, yeah, right there where you're with your rounds. And I'm trying to figure out if that's volume average, and there's also injury on the other side as well. Like, did they dislocate?
Yeah, yeah, this was a dislocation, having said
Okay. I mean, it just looks,
tearing.
yeah.
It's hard to say. This is actually bone here. So
Yeah, that's what I thought.
yeah, so that this was a medial epicondyle avulsion. All right, well, let's move on. I think you guys are probably tired of the medial side of the elbow. So let's go on and talk about the biceps. So if we look at the anterior aspect of the elbow joint, approximately here, the deep muscle is the, anybody? Okay, and the superficial muscle is the, okay, so this is the brachialis, and then the superficial one is the biceps. So the deep muscle is the brachialis. It comes down and attaches to the ulna, and the more superficial one has a tendon that attaches to the radial tuberosity here, and that's the biceps. And then there's an aponeurosis, which extends over here medially, which helps stabilize the distal muscle if you have a tear of the biceps, if it's not torn, which you're all familiar with, but we'll talk about that in a minute too. Some people are,
Yeah, the biceps. A lot of people, when they make a muscle, they brag about how big their biceps is. The strongest muscle there is the brachialis for flexion. The biceps, the strongest function is rotation.
right.
In other words, supination. I'm sorry, John, to interrupt you. There was no reason for me to do that, but I just.
That's fine. Good.
It's Friday, I guess.
Friday the 13th, even. So some people have described special views, the FABS view for this. I don't think it adds anything. This is a very easy tendon, I think, to evaluate on our standard images. So I don't think we need to do anything special on the FABS view.
I've done sports medicine all my life, never done that view.
Yeah. And then here we can see the biceps tendon coming down on the FABS view. You can see it attaching right to the to the tubercle. The one thing that we'll talk about in a minute is whether you pronate or supinate the forearm. That will change things a lot here, and we'll talk about that in a minute. So let's look at the anatomy on MR scan. Here's the coronal plane. Here, there's the biceps muscle. There's the distal tendon. There are two tendons from the short and long heads. Here's the pronator teres tendon muscle right here. Here's the extensor muscle mass over on the opposite side. And then as you can follow on the coronal plane down here, this is the biceps tendon. Generally, you can see both of them from the short and the long head on the coronal plane if you look for it. And you can follow it all the way down. And then there's the attachment, as we see here. And this is the radial tuberosity. So that's a coronal plane, and the axial plane is the plane that most people use to look at this, but you really should look at it on all three planes, I believe. This is the brachialis muscle, the most important one for flexion, as John just talked about. Here is the biceps more anteriorly, and you can see here, whoops, the muscular tendinous junction, and then we can follow it distally. There's the biceps here, and then there you can actually see both heads, and this is the retinaculum coming across here to attach from the medial side. And then you can follow it all the way down here to where it attaches to the radial tuberosity. So on your axial images, you have to go all the way down through the radial tuberosity. And one of the problems that techs will do that don't have experiences here is that they will stop the axial plane before they get distally enough, and you can't see the insertion. And you have to evaluate the insertion of the biceps on every elbow. It's a common injury, as you all know. And in the sagittal plane, brachialis, biceps tendon coming down here. This is a vein. And then you can follow the tendon coming all the way down here to its attachment on the radial tuberosity here. On the other side, this is the brachialis. Now, the thing about the brachialis is that very commonly the distal aspect of the brachialis, the muscle will attach to the ulna, and you may not have a tendon, or you may have kind of a combination of muscle and tendon, but usually you'll have muscle going all the way to the bone, at least some muscle going all the way to the bone, as opposed to a lot of other muscles and tendons where the muscle stops short of the bone. And here you can see the muscle fibers coming all the way down here to the ulna, which is common for the brachialis distally, which means its signal is a little bit different than most tendon bone interfaces. Jennifer, what do you think of this case?
Okay, so 43-year-old male with pain after bowling. We can see here distally, we don't see a normal attachment of the biceps to the radial tuberosity, and it looks a little thickened and slightly retracted more proximally. So this is compatible with a tear of the biceps. Here we can see again, it looks like perhaps a couple fibers are intact, but the majority is torn. So this is at least a high-grade partial tear.
Do you know what portion of the biceps is intact here?
Well, this is going to be the more. That's the radial head. Yeah, this is the long head of the biceps tendon.
So when we look at this distal attachment, you can see that in most patients in gross dissection, you can differentiate the long head and the short head. And the way to remember this is that short head goes long and the long head goes short at the attachment here. Right, there's a little bit of the long head still intact here. The short head and a portion of the long head are torn off the radial tuberosity here. That's kind of trivial and nice trivial information. It doesn't really have a lot of practical uses though, but it's a good thing to remember. Okay, Michael, here's that FABS view. What do you think is going on here? Michael, you with us?
Yeah, sorry, my mouse stopped working. Okay.
Put up on mute.
Get a rat.
Yeah, right.
All right, so it looks, so I see just fluid along the tendon.
Okay, so
Along the,
right
but and then maybe there's some increased signal at the tendon at its insertion to the radius.
Yeah. So this is fluid.
But that's like in the bicipital radial effusion.
Yeah. So this is often called
the bursal effusion or whatever.
It's probably partial tearing with a little bit of hemorrhage and irritation of the bursae in this area. So, and then here's another example. This is from South Korea where we can see fluid in this same bursa. I think there are 3 bursas in this area. I don't think it's all that important to differentiate.
Well, if I may cut in a little bit, I think we talked about this before, but wherever the tendons are gliding through any area that's surrounding the tendon, you have bursas, and I don't know how many to count, but they appear a lot around tendons.
Yeah.
Don't they, John?
Yes, absolutely they do, and there's probably some variability in the anatomy from person to person.
And it's good that we have them, otherwise we wouldn't have tendons as long as we do.
Right, absolutely. Okay, that's it. Are you next, Jennifer? Okay.
All right, so we have 4 axial images of the elbow. Here it seems like that distal biceps attachment is intact at the radial tuberosity. I don't see any significant retraction. Yeah. Okay.
We see that there's a lot of increased signal distally. And we don't see the good soft tissue planes around the distal tendon here or up here. And this is a partial tear. Probably a little bit of hemorrhage and maybe a chronically fibrosis in around the tendon, and that's why the soft tissue planes are kind of obscured here. You don't have normal fat going to the tendon. And this is just an example of a chronic partial, which we see here. These patients are symptomatic, and they're certainly at high risk of going on and tearing this. But if they have symptoms, sometimes surgery may be helpful even in these partial tears. Michael, what do you think of this? Who's somebody's?
It's not me.
I don't know what that
It his it looks like the mic's going off and on.
Oh, John, you must be clicking on your mic. You move your mouse. John, would you move your mouse?
I'm having trouble with my.
You're turning the mic on and off. You move your mouse off of the microphone button. John?
Yeah, I'm having.
You're turning your mic on and off. Oh, good. That's better.
Okay. So it looks like there's an increased signal at the interface of the brachialis and the ulnar insertion.
Wait, the brachialis and what?
I'm sorry, the biceps and the radial insertion.
Okay. So there's a little increase of intensity here at the distal biceps. Okay.
Yeah, and it doesn't look like a complete tear, so just maybe like tendinosis.
Right. Which we can see right along there. Now, now the stenosis can be due to impingement. And
is that impingement between the ulna?
Yeah, between the ulna and the radius. And the situation here in supination, the insertion side of the biceps tendon is anteriorly positioned. But when you go into pronation, what happens is that the radius rotates and actually the insertion side becomes posterior to the ulna. And what happens, you can get impingement of the biceps tendon between the radius and ulna, especially if you have osteophytes in this location. And here are the two major bursa in that particular area. So we typically image the elbow in supination so we can see the biceps attaching to the tuberosity without actually going through the space between the two. I suppose that if you're concerned about impingement, you might try both supination and pronation, in which case you might be able to see the impingement a little bit better. When you get these, what will happen is you'll get traction injuries, osteophyte developing here, often partial tears, and that can produce pain, especially when supinating and pronating. So just be aware of that potential pathology in this area.
So 86 years old with 1 year history of elbow pain and mass, rule out neoplasm. I see a retracted tendon with surrounding edema and fluid. I think this is a biceps tear. Yes. Okay, so here again we don't see a normal attachment of the biceps. Okay. So there is some retraction of that biceps tendon and I can't see it attaching to the radius and there's surrounding fluid and probably hemorrhage. It surprises me she's had this for 1 year, but she probably has some bicipital radial bursitis.
So this is a patient who's got a big impingement here and severe bursitis, secondary to the chronic impingement and tearing of the distal biceps. Right. Now, one thing to be aware of is that the size of the radial tuberosity varies from person to person. Sometimes it can be very large, and if they have very prominent radial tubercles, these are patients who are prone to impingement earlier than people who have smaller ones. And we can see here, and this is what it looks like in the axial plane. And some of these patients will have some limitation to pronation. Due to their anatomy of prominent radial tuberosity. Michael, what do you think of this one?
I mean, so there's this kind of mild irregularity and increased signal around that distal biceps tendon.
Okay, so now this person is actually imaged in some degree of elbow flexion because it hurts much for them to extend the elbow, and so we can see a lot of tendinopathy here around that distal biceps tendon, and here it's markedly thickened.
But it looks intact to its insertion.
Yeah.
So I don't know, it's just tendinosis.
Yeah, tendinosis.
Here.
Yeah.
Okay, so here again we have axial images of the elbow, and there is some irregularity of the soft tissue planes of the biceps tendon. It looks like there might be some fatty atrophy, so I'm wondering if this is a chronic tear of the bicep.
Okay, so this is a lower field image. This is actually the biceps tendon. It's markedly thickened with increased signal intensity and irregular. And then when we come down to its insertion, it's markedly increased signal intensity, so it has the same signal intensity of the muscle next to it. And then if you go to the T2 weighted images, this is actually the tendon. So the T2 weighted images allow us to differentiate the tendon from the surrounding granulation tissue. But this is a high-grade chronic partial tear of the biceps. These tend to be symptomatic, and in this case, with a lot of scarring in situ. And then here we can see scarring, and I think this is the same patient with thickening and splaying of the distal biceps and a lot of the scar tissue there. This is the brachialis going into the ulna. So this is I think that was ended up being a chronic tear with scar in situ, like we see in the elbow. But again, it's not functioning properly. And for those patients who are symptomatic, where it's a problem, then they can do surgery. We already had the lecture from Curl and Jobe where they talked about surgery to the biceps, right? This year or not? Maybe we haven't. Okay, well, but we'll have a lecture where we talk about the biceps and the risks and so forth, and the different kinds of surgeries done to repair distal biceps ruptures. Okay. Michael?
Okay, so there's pretty significant thickening and irregularity involving that distal biceps tendon with surrounding fluid. I'm not sure if that's within the, if that's just surrounding edema, or if that's within the bicipital radial bursa. There's at least, there's probably like a high-grade partial tear. I don't think it's completely torn by the images we see.
Yeah, and it primarily involves the short.
Yeah, short head. Yeah.
There's a lot of fluid in the bicipital radialis bursa, and a lot of tendinosis, partial tearing, and splaying of that tendon. Yeah. Okay. And he was a 57-year-old male, 3 weeks after an injury, ruled out biceps tear, and what we just see is fluid where there should be a biceps tendon here. The biceps is proximally retracted in this particular case. There's the tuberosity. That's the biceps. Oh, I'm sorry. There's the biceps, which is torn, and fluid in between the distal biceps, severely tendinotic in this location. Since it's not retracted more than this, if we go forward, markedly thickened, this is going more proximal, Here's coming up there, and here we can see the retinaculum or the aponeurosis is still intact, and that's why it hasn't retracted more superiorly. And a surgeon would like to know, you need to give them a sense of exactly where the distal end of the tendon is, what the integrity of the tendon is. This one is very, very severely tendinotic, and whether the aponeurosis is intact or not, so that they know where to go looking for the tendon if they're going to repair it. And again, very tendinotic tendon going more proximally. Okay.
59-year-old male, 1 week after a weightlifting injury. We have two sagittal images of the elbow, and here we can see a complete tear of the biceps tendon with retraction to the level of the radial head, and there's surrounding fluid in the bicipital radial bursa, and here we can see that there's some at least mild tendinosis of the retracted tendon, and the aponeurosis is intact.
Michael, you get the last case today.
All right. So 50 executive with pain and weakness. So there's increased signal regularity involving that distal biceps tendon around there. So at least some tendinous partial tear. And that
We don't see it going on.
I'm not sure if that's just the cut or if that's actually torn off the radius.
Yeah. Okay, there's the next cut up.
So next cut up, you still see some irregularity of that tendon, and I don't really see that the aponeurosis.
No, we're doing fine over here, so it must be on your end. Well, we're finishing up right now. We're going to be finished in about 20 seconds here, so we'll see again on Monday. Have a good weekend. Thank you. Thank you. Bye. So John just called, and I guess his system went out or whatever. So go ahead, Michael. So this is a little bit more proximal. Yeah. What are we seeing here?
So it's, it still looks abnormal here with intrasubstance signal. There it's kind of almost like a longitudinal split. And there it looks fairly normal up in the muscle.
Yeah, but be careful about the split. Here we can see in the coronal plane, it looks like there are two tendons there. And
yeah.
Follow it down, follow it up. There are the two tendons. Those are the two tendons of the short.
So that's just the two, the short and long head that are splitting. Okay.
And so this actually was a bifid tendon all the way down to its attachment.
Got it. Okay.
So why don't we stop here and we'll continue looking at bigger tears on Monday. Any questions? All right, then everybody have a good weekend.